I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the
Trying to Keep Cool on Summer Nights
episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
And last time we left you on £1 million question cliffhanger. So here's your question for a virtual £1 million. Regarding cholesteatoma. This is a condition which is easily missed. Cholesteatoma tends to affect the upper part of the tympanic membrane and is more common in patients who have recurrent infections. It can present with chronic painless ear discharge and reduced hearing. How often would a GP with 2,000 patients expect to see a new case? Is it A, every 2 years, B, every 5 years, C, every 7 years, or D, every 10 years? And the correct answer is B, every 5 years. So as I was saying, cholesteatoma tends to affect the upper part of the tympanic membrane and is more common in patients who have recurrent infections. It can present with chronic painless ear discharge and reduced hearing. A GP with 2,000 patients might expect to see a new case every 5 years. If a good view of the tympanic membrane is not possible, then call these patients back in 2 to 4 weeks for a second look when it's all settled. Okay, now, thank you if you took the time to send in your answer, but nobody got it right this time. We have no virtual millionaires this weekend, I'm afraid. Now, if you knew it, if you got it right at home and you didn't send your answer in, then I could have been reading out your name right now. So better luck next time. And it just goes to show that it's always worth a go because you never know if somebody has sent in the correct answer or not. Right then, we are back this week with the second half of the pearls that we sent out in July. And I'm joined again by the fabulous Ali Smith because Caroline is having a well-earned rest and is on holiday. So grab your preferred drink of choice or your trainers, clutch your pearls, maybe even the dog or a cat. And let's start with the headlines. Here's what's coming up. I think he might have worms. All things helminth revealed. Okay, it's not glamorous. It's one of those where else would you learn this but Red Whale topics. But worms or helminth infections was one of the most common unreturned searches on Red Whale Knowledge. So we wrote you an article and released it as a pearl, which we will discuss later on in the podcast.
We see a lot of discharging ears in primary care, and we often put these down to otitis externa. Otitis externa is common, but there are other causes of otorrhea we don't want to miss. We'll take a closer look at some of the pitfalls in diagnosing otitis externa and why these consultations are not always as straightforward as we might think.
So let's start this episode with our third pearl of the month, and we're talking about helminth infections or worms. Now, this one took me 11 minutes and 14 seconds to read, so another medium length one. So what did it mean for you, Ali?
Well, it is a really useful read, but it made me feel, in a word, icky.
Did it give you the ick? That's how, I think, is that the way to say it now?
It really did. I think that's what the young people say, yes.
Exactly. So, Here we go then. The most common worm infections in the UK are caused by threadworm or Enterobius vermicularis, also known as pinworm. Now, most of these are managed in the community and they don't come to our attention unless they cause complications or require off-license prescribing. Other worm infections are much rarer, but worth knowing about, particularly for those who work in migrant health with refugees or with returned travellers. Now, the UK Government Migrant Health Guide is a useful resource when considering helminth infections in migrants. In 2018, the BJGP told us that even if asymptomatic, we should have a low threshold for considering helminth infections in this population. And did you know that a love of sushi may have some wriggly consequences? So keep listening to find out more about that. Now then, Ali, can you tell us a bit more about the types of worm that are around?
Of course, I'd be delighted. So I'm going to split them up into two groups, those that can be caught in the UK and those to consider in migrants or returning travellers. So helminths that can be caught in the UK are threadworm, toxocariasis, anisakis from raw fish, and cutaneous larva migrans. And the helminth infections to consider in migrants or returning travellers are hookworm, whipworm and roundworms, strongyloidiasis and schistosomiasis.
Now, I said earlier that threadworms are the most common worm infections in the UK, so let's have a look at those, or perhaps it might be more palatable to say let's consider them instead. And an article on common intestinal parasites in American Family Physician from 2004 has helped us with this overview. Now, as always, full references are in the written Pearl and on Redwell Knowledge. Threadworm infection is almost ubiquitous amongst young children, and adults are also frequently affected. Threadworms cause an intensely itchy bottom, mostly at night, when the female worms come out to lay her eggs around the anus. Threadworms are white or beige and 2 to 13 millimetres in length, though I'm pretty sure that we're not going to be measuring them. In fact, I'm certain we won't be measuring them. They can sometimes be seen around the anus or in the stool. Now, each female can lay around 15,000 eggs. Scratching the bottom transfers eggs to the fingers and under the fingernails, where they can be ingested, leading to a cycle of reinfection. Eggs are quite hardy, lasting up to 2 weeks, and can be deposited around the house, often infecting other family members and making it hard to eradicate infection once it takes hold. Stool testing for threadworm is not usually necessary. Common symptoms would be anal itch, poor sleep and irritability, and less common symptoms are vaginal itch and dysuria, abdominal pain, it can actually mimic appendicitis, and dysphagia. So what about treatment, Ali?
Well, treatment of threadworm infection is with anti-helminthic drugs and with hygiene measures, or you can use hygiene measures alone. Now, these hygiene measures are pretty onerous to follow, including washing sheets daily for several days. I mean, really? So it's easy to get into a cycle of repeated infections, and no nursery or school exclusion is required. Hygiene measures should be continued for 2 weeks after treatment with medication, or for 6 weeks if used alone, for example, during pregnancy. And we've got that and the following facts from the BNF's information on mebendazole, which we accessed in May 2024. So mebendazole is what we'd use to treat, and it's available over the counter. We usually give 100 milligrams orally in a single dose, and it's not licensed in under 2-year-olds, although you can do an off-label prescription in children between 6 months and 2 years of age. We should avoid it in the first trimester of pregnancy. And after the first trimester, we can consider using mebendazole if hygiene measures alone fail. But we need to consider the risk versus benefit, and this is off-label. In breastfeeding, the manufacturer advises avoiding, but the amount in breast milk is too small to be harmful. Nick, these hygiene measures that I keep mentioning, can you tell us a bit more about them, please?
I can, and I will. And it would also be a good idea to signpost patients to the NHS website and their section on threadworms. And I'll put a link in the show notes for that. So these hygiene measures may be used alone if under 6 months of age or pregnant. And so what we need to do, wash hands and scrub under the fingernails after using the toilet, before eating and after changing nappies. We should encourage children to wash their hands regularly. We should rinse toothbrushes before using them. We should shower each morning. Disinfect the kitchen and bathroom surfaces with hot water. Vacuum and dust with a damp cloth. Everybody in the house should wear underwear at night and change it in the morning to reduce the ability to scratch the anal area and recontaminate the fingers. Sheets and towels need to be washed daily in hot water for several days following treatment. And hygiene measures should continue for 6 weeks if used alone. Whew. So, Ali, you've got something about a great mimicker there, haven't you?
Yes. So this is really interesting. Perianal streptococcal dermatitis can be misdiagnosed as threadworm infection in children. There's a really helpful BMJ article from 2009 which tells us to always examine the anus of a child who's not responded to empirical treatment for threadworm. So this infection is caused by group A strep pyogenes, and it mainly occurs in prepubescent children with a peak incidence between 3 and 5 years of age. And it presents with pain around the anus, worse on opening the bowels, and you can see a well-circumscribed circumferential erythema around the anus, and you can see fissuring too. It can be diagnosed by taking a perianal swab, which will culture a pure growth of group A strep. Treatment is usually with oral penicillin or clarithromycin. So go on then, Nick, tell us about sushi.
Well, raw or undercooked seafood, including wild-caught salmon, cod, herring and squid from UK waters, may be contaminated with the worm species Anisakis. This can elicit an allergic reaction with angioedema, urticaria or anaphylaxis. The worm can also invade the stomach, intestine or peritoneal cavity. Gastrointestinal infection often presents with fever, abdominal pain, nausea and vomiting, mimicking an acute surgical abdomen. Complications such as intestinal bleeding, bowel obstruction, perforation and peritonitis have also been reported, and that's from a BMJ case report published online on the 17th of May 2017. It's well recognised in Japan but rare in the UK. Cooking or freezing of fish will kill the worms, and the Food Standards Agency requires freezing of fish intended to be consumed raw prior to sale or consumption. There is currently no risk with farmed fish. What about a worm under the skin, Ali?
Oh, well, this one sounds like something from Doctor Who when you say it like that, doesn't it? What we're talking about is cutaneous larva migrans. So this is due to infection with animal hookworm from dogs, cats and other animals. And humans usually become infected by walking barefoot on sandy beaches or on moist soil that's been contaminated with animal feces. And the worm penetrates the skin of the feet but cannot penetrate past the basement membrane. So instead it wanders around lost until it dies 4 to 8 weeks later. So humans are a dead-end host, and the worm is unable to reproduce in humans. But during its wanderings, it can be seen as a raised pink, serpiginous, migratory and intensely itchy rash under the skin. No treatment is required because the infection is self-limiting.
Yes, but 4 to 8 weeks of an intensely itchy rash.
Well, yes, fair. So treatment with topical or anti-helminthics can be offered, and it can shorten the duration of the infection and reduce the itch.
Yeah, I think I'll be asking for the treatment.
Yeah, I think I would too, Nick. And it's usually acquired overseas, where walking on the beach barefoot is more common than in the UK, and the beaches are more likely to be contaminated with animal feces. But locally acquired cases have been reported in people like joggers who get splashed with moist soil. And that's from a BMJ case report published in 2015.
So to wrap up, we're going to consider migrant health and helminth infections. And firstly, hookworm, roundworm and whipworm in migrants or returning travellers. Now, hookworm, roundworm and whipworm are all transmitted through ingestion of soil contaminated by feces containing eggs. This occurs in areas of the world with poor sanitation. Up to 20% of migrants from endemic countries may have helminth infections on arrival in the UK. Many infections are asymptomatic and self-limiting. Consider soil-transmitted helminth infection in migrants from the Indian subcontinent, Indonesia, or sub-Saharan Africa. With eosinophilia, up to 60% of eosinophilia in this group is likely to be due to helminth infection. Also, unexplained gastrointestinal symptoms or anemia. Hookworm infection is a major cause of anemia in endemic areas. Treatment is with oral mebendazole 100 milligrams twice daily for 3 days.
So next, let's turn to the BMJ in 2013 and consider strongyloides in migrants and returning travellers. So strongyloides infection, or Strongyloides stercoralis, is also transmitted via contaminated soil. But here, the larvae penetrate the skin, usually in the foot, causing an intensely itchy rash before migrating to the bloodstream to reach the lungs. And from the lungs, they reach the gastrointestinal tract through swallowed mucus. And this infection is endemic in tropical and subtropical areas, including South and Southeast Asia and the Caribbean, Sub-Saharan Africa, South America and Northern Australia. But cases have also originated from southern Italy and Spain. And in strongyloides, up to 60% of infections are asymptomatic, and eosinophilia might actually be the only clue. About 20% of people will have vague gastrointestinal symptoms such as nausea, vomiting, abdominal pain and bloating. An invasion of the lung can cause recurrent respiratory symptoms, including fever, wheeze and pneumonitis. An infection can be lifelong. Reactivation of infection with serious complications can occur in immunosuppression, for example, people on steroids or undergoing chemotherapy. Treatment is with oral ivermectin, although this is unlicensed.
So finally, let's consider schistosomiasis in migrants or returning travellers. And there are two main species of schistosome: Schistosoma hematobium, which is the urogenital version, and Schistosoma mansoni, the intestinal version, and they are acquired from infected snails in tropical fresh water, particularly in sub-Saharan Africa, where it may affect up to 20% of residents and travellers. The freshwater snail is an intermediate host. Chronic infection can lead to long-term complications, hence the importance of detection and treatment. Schistosoma hematobium, the urogenital infection, would have symptoms of hematuria, either macro or microscopic. In women, it can cause dyspareunia, vaginal nodules and vaginal bleeding. Complications-wise, it can cause kidney damage, bladder cancer, infertility in men, and ectopic pregnancy. Schistosoma mansoi, the intestinal infection, presents with abdominal pain, diarrhea, blood in the stool as well, and its complications would be liver or spleen enlargement, ascites or portal venous hypertension. Treatment of schistosomiasis is with praziquantel. If you want some more detailed information on schistosomiasis, then there's a link to a fact sheet from the WHO all about it in the written Pearl, and I'll also put a link to it in the show notes as well. So here are your learning points for worms or helminth infection. Threadworm infections are common. Medications are not licensed in pregnancy or under 2 years of age. Perianal streptococcal dermatitis can mimic threadworm infection.
Anisakaiasis from eating raw fish and seafood can present as an acute abdomen. Cutaneous larva migrans causes a distinctive migratory raised pink, serpiginous and itchy rash.
Think of worm infections in returned travellers, migrants and refugees. Eosinophilia may be a clue. Okay, so now it's time for our group hug, which is the part of the podcast where we celebrate getting through a difficult day in primary care with our best intention story. And we need your help to put a smile on everybody's face. So when you listen to the story this month as we do it, have a think about what your best intention story would be, and please send it in, and our contact details are in the show notes. And this month the story is from M in Shropshire. Dear Ali and Nick, after having a good old giggle at the rice in the air story last month, I was compelled to tell you my story. I used to work in a rural practice and had developed a lovely relationship with a fun, eccentric, and some might say a rather well-to-do patient. He'd often pop in to see me on his way to or from the garden centre. His wonderful garden was the talk of the village. Now one day he came to see me and his jolly face brightened up my consulting room. He plonked a half bottle of champagne on my desk and I tried to conceal my inner glee. For once, I was the clinician who would be carrying something special home. I started to thank him and tell him how kind he was, but he really didn't need to get me any gifts. But then I noticed something wasn't quite right. The half bottle of champagne was already open. Oh no, I thought, this has taken a turn. Now I was going to have to sort of tell him about drinking alcohol and even champagne, saying that in the morning it wasn't a good idea, and offer him any kind of support that he needed with problem drinking. He looked bemused as I tentatively asked him about how often he needed to have an eye-opener. Then he started laughing, a proper belly laugh. I'm sorry, doctor, that's no champagne in that bottle. I'm sorry to get your hopes up and then to worry you, but I didn't have a specimen pot, and so I've produced you a urine sample in the only suitable receptacle I had to hand. So there we are. So my learning points are, never assume that you've been bought a gift. Beware the open bottle of champagne. Never be tempted to take a swig, ever. And always check the contents of a bottle before launching into a lecture. So thank you for that story. And if you have a best intention story, then please do send it in to us at the usual address, which is in the show notes. So there you go, Ali. Has anything like that ever happened to you?
Thankfully not, Nick, no.
Good, so no champagne swigging. So,
only in my free time.
Yeah, exactly. Have you got the Red Whale calendar for us?
Yes, I have. So this time of year is kind of the creative season at Red Whale. We're finalising our next bunch of articles. We are filming some content for the blood test course, which will launch later this year. And we're getting ready for the big filmathon for all the new content for the GP Update season, which I think you and I might be doing a bit of filming together for that, are we?
Yeah, we are, which is exciting. We're certainly working together on some of this stuff. So I'm just thinking about what I need to be working on and make a few notes about that. Yeah. It's all going to be fine. Deep breaths. So that's cool. So that's all exciting. And also, are we doing some webinars for GP trainees as well?
Yes, we've got a very exciting series of webinars for the GP trainees coming up too.
Brilliant. So stay tuned for that. So yes, we're in the creative season, as Ali was saying, and that will come to fruition in the autumn, where you'll be able to see all the new content. Right then, on to our final pearl now, and otitis externa and otorrhea. Now, this one took me 7 minutes and 58 seconds to read, so the shortest one of the month. So, Ali, what did this one mean for you?
Well, this one feels very topical at the moment because it's the time of year where we're starting to see a lot of people coming back from their holidays, having spent a lot of time in the pool.
Yes, and it's one of those questions that I always ask patients now. They've got earache. Have you been swimming recently? And they often say yes at the moment. So the classical symptoms of otitis externa will come as no surprise. Pain, itch, discharge, and hearing loss. However, not all symptoms are present in all patients, and it can be difficult to distinguish otitis externa from other common causes of painful or discharging ear, including otitis media. So let's consider the symptoms in more detail to ensure that we don't miss other causes of otorrhea. Systemic symptoms such as fever, headache, or loss of appetite are unusual for otitis externa and should prompt us to reconsider the diagnosis. Now, we've used BMJ articles from 2021, 2014, and 2011 to help us with all of this, and the full references are in the written pearl. So let's start with pain. Now, pain is the predominant symptom of otitis externa, affecting around 70% of cases. Now, the older BMJ review from 2011 reminds us that pain tends to accompany the discharge with otitis externa, but comes before the discharge starts with otitis media. Moving the tragus or pinna will elicit pain in patients with otitis externa, and deep or severe pain out of proportion to the rest of the presentation should make us wary of more serious conditions such as malignant otitis externa, and more on that later, so keep listening.
Itch is next, and persistent itch may be a symptom of the infection itself, but could also be an indicator of underlying dermatitis, such as eczema or seborrheic dermatitis, as a cause for recurrent otitis externa. Discharge from bacterial infection may appear white and purulent. It's usually scant, but it can be thick. Discharge from a fungal infection can be white, black, or grey, and it may appear fluffy. Fungal spores might even be visible. Hearing loss in otitis externa is usually caused by narrowing of the ear canal from swelling or discharge, so it should improve as the infection is treated. And you can have a look at our hearing loss gems on Redwell Knowledge for more detail on how to assess that. Which brings us to tinnitus. Pre-existing tinnitus may be worsened by infection, but otitis externa is not usually a cause of isolated tinnitus. We also have a gems on tinnitus over on Redwell Knowledge if you want to go into more detail on that. Nick, can you tell us about risk factors for otitis externa, please?
Well, there are quite a few of these, Ali, and some you might have thought of and others not so much. So the risk factors for otitis externa are water exposure, hot, humid environments, previous ear surgery, immune compromise, including diabetes and older adults, skin conditions, including eczema, seborrheic dermatitis and psoriasis, hearing aid use or other in-ear devices such as earplugs or earbuds, and trauma, often from cleaning or scratching. Now, we started the month with 5 pitfalls of REDS, and now we're going to finish with 5 things not to miss when diagnosing otitis externa. So I'm going to kick off with number 1. So your first pitfall is misdiagnosing it as otitis media. Otitis media with perforation also causes a painful discharging ear with reduced hearing. So distinguishing between this and otitis externa can be difficult. And it's even harder in a screaming child or when the eardrum is obscured by discharge. History can point us towards the most likely cause. So remember, discharge in otitis media usually comes after the pain, and there are often accompanying upper respiratory tract infection symptoms. There may also be a fever. Otitis media with perforation is less common in adults than it is in children.
And our second pitfall is this a fungal infection? 2% of otitis externa is fungal, usually Candida or Aspergillus. So we should consider this when otitis externa fails to improve with topical antibacterial treatment. And we're more likely to see it with previous antibiotic use, in diabetes and in immune compromise. And you might see white Candida or black Aspergillus fungal spores in the ear.
Pitfall 3 now, and malignant otitis externa. Now this is rare but serious. Malignant otitis externa is osteomyelitis of the temporal bone secondary to otitis externa, where infection spreads along the skull base, affecting soft tissues, cartilage and bone. Consider the diagnosis in people with non-resolving otitis externa associated with disproportionate pain and fever, particularly in the presence of diabetes, immune compromise or in older adults, and 90% of malignant otitis externa occurs in people with diabetes, also in the presence of cellulitis, if there's associated vertigo or hearing loss. Think about it if there is cranial nerve involvement such as a facial nerve palsy, and if you suspect it, then you need to refer urgently on the same day to ENT for review.
On to pitfall 4 then, and cholesteatoma, which is easily missed. Cholesteatoma tends to affect the upper part of the tympanic membrane, and it's more common in patients who have recurrent infections. It can present with chronic painless ear discharge and with reduced hearing. And a GP with 2,000 patients might expect to see a new case every 5 years. If a good view of the tympanic membrane isn't possible, we should call patients back in 2 to 4 weeks for a second look when everything's settled to rule this out.
And so to our 5th and final pitfall, foreign body, which is a mimic. Now, foreign bodies can mimic or cause otitis externa, and it can be a very satisfying discovery when you find one, but it's also another good reason to routinely examine patients with ear symptoms. Now, if you can't safely remove it in primary care, then it will need to be referred to ENT. Now, what about treatment for otitis externa, Ali?
Well, treatment has three purposes: to relieve symptoms now, to address the underlying infection and inflammation, and to consider any prevention that may be necessary to avoid future episodes. So let's start with symptomatic treatment. So as pain is a predominant feature for most people, pain relief should be recommended. And we should advise self-care measures, things like a warm or cold flannel to the affected ear and simple analgesia with paracetamol or ibuprofen. That's from the NHS website ear infection section, which is useful to signpost to.
So let's consider topical treatments next, and there is an absence of high quality evidence comparing different topical treatments for otitis externa head to head. In 2010, Cochrane published a review of interventions for acute otitis externa. A meta-analysis of 19 trials showed that topical antibiotics, antiseptics, glucocorticoids and acidifying agents were similarly effective at treating otitis externa. So bearing this in mind, our options include topical acetic acid 2% spray, topical antibiotics and topical antifungals. So topical acetic acid 2% spray, now that might be used in mild cases. And with topical antibiotics, they can be split into two groups: aminoglycoside drops and fluoroquinolone drops.
Yes, so with topical aminoglycoside drops, in the UK, these drops, things like gentamicin, are often advised for otitis externa because Pseudomonas and Staphylococcus make up most of the infections. Now, theoretically, they are contraindicated in people with a known tympanic membrane perforation, but they can be used on specialist advice.
So do I need to worry about aminoglycosides causing deafness?
Well, even in patients with perforated eardrums, aminoglycoside eardrops will not reach ototoxic levels within short courses of 1 to 2 weeks. However, the drops can remain in the inner ear for up to 6 months, so we need to be careful around using repeat courses.
Wow, absolutely. I didn't know that. Okay, so fluoroquinolone drops are the other type of topical antibiotic. Ciprofloxacin 0.3% eye drops may be used off-license to treat otitis externa, and the BNF suggests using 0.25 mils or 0.5 milligrams twice daily for 7 days. Now, most droppers dispense 0.05 mils per drop, so this would equate to 5 drops. Obviously, always check what is written in the BNF. So the final topical treatment option is topical antifungals, and clotrimazole 1% is available as eardrops for fungal otitis externa. Acetic acid may be used off-license. So what about oral antibiotics, Ali?
Well, oral antibiotics are actually rarely needed for straightforward otitis externa in primary care. So in 2001, the BJGP told us that they are less effective than topicals, and they can also cause unwanted side effects and promote antibiotic resistance. So they should only be considered where there is extension of infection beyond the ear canal, as in cellulitis, or where there's host risk factors, including diabetes and immunocompromise. And cellulitis can be a sign of more serious infection or of malignant otitis externa. If we're prescribing oral antibiotics, topical antibiotic drops should actually be used alongside them. And as a good rule of thumb, if you're thinking your patient might need oral antibiotics, then we probably need to be thinking too about whether we need to refer them to ENT to exclude malignant otitis externa. So Nick, how do we prevent otitis externa?
Prevention is focused around reducing exposure to the risk factors that I mentioned earlier. Managing any underlying conditions such as diabetes, eczema, seborrheic dermatitis or psoriasis to reduce the risk of infections may help. Patients should avoid using a hearing aid or other in-ear devices in the affected ear until the infection has settled. The old adage of don't put anything in your ear smaller than your elbow is not ancient folklore, and we should give advice to avoid hazards such as using cotton buds, bent paper clips, who would do that? Toothpicks, Keys? Please don't do that. We shouldn't be using any of those things to itch our ears or to clean them with either. But we also need to be careful when we're saying that, not to actually give them ideas or what they could do. So it's a fine line there. And for those with a history of infection related to water exposure, then we should advise patients to keep their ear dry until the infection is fully resolved and take steps to prevent water getting in the ear during swimming or bathing.
So the BMJ practice pointer from 2021 that we've been looking at states that 65 to 90% of people will improve clinically within 7 to 10 days. And those who still have some symptoms after 7 days should continue treatment for up to 2 weeks. If symptoms haven't resolved at that 14-day point, that should be considered a treatment failure. And that should prompt us to think about swabbing and or referring these people to an ENT rapid access clinic, depending on the clinical picture. We should also consider a swab in a few other situations, which are recurrent or chronic otitis externa, if infections spread beyond the external auditory canal, and in severe infections. And what about referral, Nick?
ENT emergency clinic referral is advised when adequate treatment of otitis externa is not possible in primary care, and this may include when there is swelling causing complete canal stenosis requiring a wick for treatment, a complete canal occlusion due to debris or discharge requiring microsuction to allow topical treatment to penetrate, treatment failure, as Annie just mentioned, and malignant otitis externa. And remember, this is an ENT emergency and warrants same-day referral. Many ENT departments will run emergency clinics to enable people with conditions such as otitis externa to be seen on the same day. And remember that suspected cholesteatoma should prompt ENT outpatient referral as well. So, here are your learning points for otitis externa and otorrhea. Otitis externa is a common cause of otorrhea, but other causes should be considered.
Malignant otitis externa is an ENT emergency. Symptoms include disproportionate pain, fever, and facial nerve palsy. Cholesteatoma can be a complication of recurrent or chronic ear infections.
Aminoglycoside drops can be used for short courses in ears with a perforated drum. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. How do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else, no matter how hard you try. Please also note that this voucher code is all one word and all lowercase, Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review. And because of the way the algorithms work, it means that other people just like you can find us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedWhalePod.
And the other thing that you can do if you click on a link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@redwhale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.